Welcome to this satellite symposium presented by Lambda, a Thermo Fisher scientific brand. The moderator for this session is Robert Montgomery from NYU Langone Health. Please stay tuned after the session talks for the panel discussion. If you would like to submit a question directly for the session moderators, please utilize the Q&A feature on the side panel of your screen. Enjoy the session.
I'd like to welcome our audience. This is a symposium that is being sponsored by Lambda. The title of today's meeting is Personalizing Post-Transplant Care. Can precision diagnostics improve patient outcomes? Every patient deserves individualized care supported by the most advanced diagnostic tools. In this presentation, we'll discuss methods for improving diagnostic accuracy with a detection of donor-specific antibodies, robust screening for COVID-19 antibodies, and quantitative biopsy assessment using the Molecular Diagnostic Microscope. Our first speaker today is going to be Dr. Phil Halloran. He's a clinician scientist and distinguished professor of medicine at the University of Alberta, where his research focuses on molecular tools to diagnose different phenotypes involved in rejection and allograft injury. Our second speaker is Dr. Michelle Hickey, who's the Associate Director of the Immunogenetics Laboratory at UCLA and an Assistant Professor at the UCLA Geffen School of Medicine. She'll be speaking about post-transplant DSA monitoring. And our third speaker is Dr. Steve Woodle. He is the chair and a professor of surgery, as well as the director of the Solid Organ Transplant Center at the Cincinnati College of Medicine. And he'll be speaking today about COVID-19 testing for transplant patients. So let's begin our discussion. So first up is Dr. Phil Halloran, whose presentation will be about the molecular microscope.
We're going to be discussing how we're discovering the molecular basis of organ transplant, rejection, and injury in the MMDX project. These are my disclosures. So I'd like to present to you about 10 new discoveries that we're seeing. The principle of this project is that if you can't measure it, you can't change it. What we're trying to do is measure changes and then interpret them. Many of our conventional clinical assessments are actually qualitative or at best semi-quantitative and vary between observers. And we tend to defer to eminent experts, but that's actually, there's a lot of disagreement between the eminent experts. Histology, radiology, clinical diagnoses in the clinic. Now, conventional diagnostic systems are noisy because of this inter-observer disagreement. They're not too bad with normal versus abnormal, but when you get into what type of abnormal, you get a lot of disparities. And we've published these disparities, and so has the histology literature in the degree of agreement between observers in kidney, heart, lung, and liver. Now, when we're looking at molecular changes, we have to expect that the degree to which a molecular system agrees with a conventional system will be limited by the noise in the conventional system. You basically can't agree with a system more than it agrees with itself. So the reason we're doing this is to understand mechanisms and to bypass the high error rate in conventional systems, and thereby to improve care. When we're assessing human tissue, we want precision measurements that are reproducible. We want to represent the organ. We want accuracy, and this means going constantly back to the clinic and trying to find out if this represents what's going on in the patients. The patients are the truth. We want to standardize it so it's the same for all centers. So if it's 42 in Melbourne, it's 42 in Munich. And we want to personalize it. Does it retain the uniqueness of each patient? You've seen this before. This is probably where we are, where we've got scatter in the measurements and we're not hitting the mark. This is accurate but imprecise. This is precise, but it's not accurate. And this is where we want to be. So the opportunity that molecular systems present to us is to measure genome-wide molecular changes, and we do it in intact RNA, reflecting a rejection and injury. And then we apply many machine learning algorithms And incidentally, we retain the RNA forever. Now you have a system for going back and applying new platforms to that RNA 10 years from now. So we published reasons why we think that genome-wide molecular measurements interpreted by ensembles of machine learning algorithms will be more precise and more accurate than histology. But the point is, we're trying to understand the patients and using all available platforms. This is not a competition. So the true disease state is elusive. We're always discovering it. Conventional systems estimate it. Molecular systems estimate it. We can then make many estimates, 100 estimates, like 100 different people reading a biopsy. And then we can describe the relationship to conventional assessment and make each of them better. They can be mutually informative. The goal of MMDX is not to agree with histology, it's to discover the truth and describe the relationship to histology. So MMDX is a central diagnostic system that uses genome-wide microarrays to measure gene expression in intact RNA with high precision, and then compare the biopsy measurements to a reference set using ensembles of predefined machine learning algorithms. We measure 50,000 probe sets, this is genome-wide, and then we interpret the states, the rejection states, the injury and wounding states, the prognosis, and then from the clinical point of view, we try to understand the situation that that patient may be in, the clinical scenario, like under immunosuppression, non-adherence. You take a piece of the biopsy, the piece of the liver core, the piece of the kidney core. The recent BANF report said that we require a whole core. That's not true. It's never been true. And then we can also take bites of we can take endomyocardial biopsy bites, transbronchial biopsy bites, and mucosal biopsy bites from lung. You take the human tissue, you put a bit of it in RNA later, you put it in FedEx, it comes to us overnight. We extract the RNA, we label the RNA, we hybridize it to the microarray, and then we develop the color from the label in the microarray. That turns into a spreadsheet, and our algorithms turn that into a report. Kidney and liver, this is 24 hours, it's overnight. The small bite biopsies take 2 nights. This is supported by a huge number of investigators, currently about 99 investigators in more than 40 centers, but we're acquiring more investigators every day. And we're very grateful to the many people who have committed to this project. If we're successful, it's their success. Now, why do we use fresh RNA? If you take the tissue from the biopsy and you take 2 pieces in RNA later, then you get a line because they're both intact RNA. If one of the pieces has been put through formalin fixation, it is covalently changed forever. This creates false positives and false negatives compared to the truth, which is the fresh RNA. You can do this. It's just we choose not to because it's just never going to be as good. That's why we use fresh RNA. And incidentally, then that's why we have a fresh RNA sample from that patient forever. So these are our clinical trials. Everything I'm talking to you about is a patient consented to give us their biopsy, and it's prospective and regulated by IRBs, every single biopsy. So the kidney system, based on discoveries using experimental mouse models and then human biopsies, and then we've relied on supervised and unsupervised analyses, principal component analysis, and archetypal analysis. And these generate the ensemble of estimates that help us get precision and accuracy. You've seen this before. This is how all our biopsies are currently signed out. So the biopsies, each biopsy is in our reference set is characterized for its rejectionness using machine learning algorithms. So we find that principal component 1 is no rejection versus rejection. Principal component 2 is T-cell mediated rejection versus antibody mediated rejection. Then we apply archetypal analysis for groupings, and we get early stage, fully developed, and late stage ABMR, and 2 TCMR phenotypes, which we're starting to understand. If you take that cloud of biopsies, that's a cone-shaped cloud, and you rotate it out toward you, you look down the barrel of the cloud, and now you can see the diversity in ABMR. Early stage, fully developed, and late stage, but no diversity in TCMR. Then we take the new patient, and your patient then is projected into the data cloud. And you can see what the other people that have had this situation have done. This expresses the uniqueness of each patient rather than just putting the patients into a bucket. And this is our report, and that report is signed out, and the report is signed out is mostly automatic, but we always have a human observer who's trained in these things look for detail which might be helpful to the clinician. Now, we can take all our biopsies in the reference set. This is currently about 1,679 biopsies, and we can distribute them in a system that collapses all the dimensions of change into two. This is called UMAP. I call this the rejection bunny. And this is the rejectionness of 1,679 biopsies. And so there's the ABMR ear, the TCMR ear, and they're colored by the way that we signed out the reports when it went back to the clinicians. And a huge number of biopsies we say have no rejection. You can see the diversity in TCMR and the TCMR ear, and I'll come back to that. But right now I'm interested in what's going on. Why does UMAP say there's so much diversity in biopsies we're saying have no rejection? And the answer comes back. First of all, there's heterogeneity in the TCMR episodes. Just let me show you the TCMR ear. What we're seeing is that the heterogeneity in T-cell mediated rejection, which is principal component 4, is and can't be actually shown in these diagrams, seems to be related to differences in the ability of that episode to express gamma interferon. So this is our new cloud generated in 1,679 biopsies. Again, we have TCMR1 and TCMR2. And they're not distributing in PC3, but they certainly distribute in PC4. And the distribution in PC4 correlates with the ability of that episode to make gamma interferon. And the TCMR1s are earlier, TCMR2s are later, but they're overlapping. We think TCMR2 may be a stage in clonal exhaustion in that patient, that those are partially exhausted clones generating that phenotype. And we're working on that. And of course, the final phase is that you can't generate T-cell mediated rejection at all. So after 10 years, in 1,679 biopsies, we've only seen 5 T-cell mediated rejections. These phenotypes are very robust. This is our next 1,600 biopsies, 1,700 biopsies, and we've got the same distribution. So we've been looking at the no rejection biopsies to see if there is something going on we should know about. And we've asked, some of these are DSA positive patients. So we've said, are the DSA positive patients showing changes of very, very mild ABMR? And it turns out there are mild ABMR-like changes of unknown significance, or MALCUS, in many biopsies we consider to have no rejection. And this we have never known before. So ordinarily we see ABMR, and we see that the ABMR status is either positive, or some patients don't have it. So some biopsies are positive, some are negative. The DSA status of that patient is usually positive, but now increasingly we're seeing DSA negative ABMR. And it's histologically typical, it's molecularly typical, and it's DSA negative. And so far, we can't see any evidence that autoantibodies explain these cases. We also see DSA positivity in many patients that have no ABMR. So supposing we took that problem of no ABMR, no rejection, and we expanded it. So now we're taking the rejection negative cases and we're dividing them into 2 classes, those that have molecular changes like ABMR and those that don't. And we're finding that the molecular changes of ABMR at a very low level in biopsies we have said have no rejection, and histology have said have no rejection, actually are associated with DSA positivity in many cases. So now we've got a phenomenon we had no idea about. So let's go back to the rejection bunny. When you take the big gray cloud of no rejection and you color them by the molecular classifiers saying whether or not there is ABMR, and one of them is called ABMR probability, and the other is called DSA probability, 2 molecular classifiers. And this is the DSA probability. So what this classifier is doing, it's defining a gradient of ABMR-like changes from the bottom of the no rejection nose to the top of the ABMR ear. And so what we're seeing is that there are ABMR-like molecular changes at a low level in many biopsies we're calling no rejection. And statistically, they're associated with increased DSA in those biopsies. So this is the biopsies below the median of the classifier, all no rejection, have this incidence of DSA. Biopsies above the median of the classifier have an increased frequency of DSA. All in biopsies we've called no rejection. I'm not going to show you all these numbers. The point about these numbers is when we take all the molecules we have said are definitively associated with DSA, with DSA in the entire population, those molecules are increased in the biopsies with no rejection that are DSA positive, whether they're defined by our archetype, defined by the sign out, or defined by histology. There's a mild increase in ABMR-related molecules in biopsies with no rejection when they're DSA positive. So this is new. So why should you care? If we look across the whole population, at the time of an indication biopsy, DSA is not associated with the prognosis. It's what's in the biopsy that determines the prognosis. And we've published that. If you take the molecular scores, they are associated with the prognosis. So these are the 2 ABMR classifiers. If you have high ABMR classifiers across the whole population, you have a worse prognosis. Let's look in the biopsies that have no rejection. These are the biopsies we've signed out that have no rejection. Again, DSA doesn't matter to your future, but molecular changes do. So in biopsies that have no rejection, the DSA-related and antibody-mediated related mild molecular changes seem to be associated with future deterioration. This is unexpected. So to summarize, no rejection biopsies with increased ABMR and DSA probability scores, molecular changes of ABMR, they have mildly elevated ABMR-associated molecules, they have more DSA, and they have a mildly elevated risk of graft loss. So low-level ABMR-like molecular changes are considerably more common, possibly as much as twice as common as we had estimated by ABMR molecularly or by histology. Now, one of the aspects that we're very interested in is parenchymal wounding, because that determines function and that determines outcome. So the patient came to you for parenchyma. That's what they need. And so we are very interested in how the parenchyma is performing. And we've spent a long time on this. This is our first definition of AKI-related changes, and we find those now in all the organs, hearts and livers, et cetera. You can't see this with histology. These are molecular changes of injury, acute injury or recent injury. We've also mapped the changes of atrophy fibrosis. And again, you can see these in histology and the changes of atrophy fibrosis, for example, mast cell transcripts, B cell transcripts, and immunoglobulin transcripts, as well as AKI transcripts. They reflect the mild inflammatory change that occurs in tissue as it undergoes scarring. Interestingly, fibrillar collagens are not a feature of scarring. Fibrillar collagen transcripts are not a feature of scarring. They're a feature of acute injury. So when we've done principal component analysis and archetype analysis, et cetera, in all grafts and in pure ABMR, the determinants of outcome are at the time of indication biopsy are not DSA. They're actually not ABMR prob inside pure ABMR. Inside pure ABMR, the ABMR signal is not what determines the outcome. It's the injury signal, acute injury and scarring. Now, this seems paradoxical, but that's what the data is. And if we look in random forest for the determinants of survival, orange is molecular, green is clinical, blue is histology. The top determinants in all biopsies are the molecular injury signals. This is the IRATs and some classifiers based on function or scarring. And GFR, proteinuria. So that's basically, these are kidneys and they're behaving like kidneys, except now we have molecular features of the kidney to tell us whether it's going to fail. Rejection comes in down here. And within pure ABMR, again, it's the GFR and the molecular injury that determines outcome, not the ABMR signal, and certainly not DSA. And if we just use the molecular signals and the histology signals, again, we find the molecular signals are the determinants of outcome. This may seem paradoxical. Maybe we should come back to it. Then we go back to what I showed you earlier, the mild molecular changes of ABMR in the no rejection group. And once again, they determine outcome because those signals are associated with injury. These are our injury classifiers. Now, this actually asks us to look again at injury and see what we can find there and treat injury like we've treated rejection. Just use all the same analyses. So we find that the biopsies distribute on the basis of their injuriness now, not their rejectionness, distributed into perfect. This is where I'd like my kidney transplant to be if I was having a kidney transplant, because they have really outstanding outcomes. CKD and AKI, and we find 2 AKI phenotypes, and this is a real surprise. This one seems to be milder, right? Except it's not. In principal component 3, it's separating. You know what it is? It's AKI that is not responding to the injury. They don't get inflamed. They don't get the molecular changes, but they have terrible function and they don't do well. So now it's just how much, not just how much injury you have, how much response to wounding do you have? And response to wounding is probably a good thing if you can standardize how much you've been wounded. We get this same picture in the next 1,500, 1,400 biopsies. Exactly the same distribution. So this is, again, a robust feature of the transplant population. We can express this in, this is called the injury pickle. This is UMAP. And it's taking all that, the same biopsies and now expressing them flattening out all the variants in the biopsies. And so we get the perfect kidneys, AKI, separating it into two groups, CKD. The triangles show who failed in the subsequent 3 years. Great to be perfect. Not great to have AKI1, not that great to have AKI2 either, and certainly you don't want to have CKD. The combination of AKI and CKD, incidentally, is bad. Incidentally, this probably applies to all kidney disease, not just transplants. Now, when we look at hearts, we've been excited to work on hearts. We had to start differently because the histology has lower kappa values, but we're basically reaching the same place as we have reached in kidneys. And so I'll just show you the highlights. This is our current report. So this is no rejection. This is antibody-mediated rejection, T-cell-mediated rejection. We define an inflammatory injury phenotype in the early biopsies. But this biopsy happens to be in the area. There's a lot of variation in the no rejection biopsies. Well, that looks like what we're seeing in kidneys, doesn't it? So this is how we currently sign out the biopsies in the new classification. There's perfect, no rejection, normal. Minor changes, possible ABMR, possible TCMR in orange, TCMR. And then we have a few cases with this early inflamed injury phenotype or early post-transplant. So that's how we sign them out. Where do the failures come? Funny, but they're not coming in ABMR. No, rejection is not the determinant of outcome in hearts either. It's injury. But for some reason, we're getting relatively few failures in ABMR. The ABMR phenotype has to be understood as being relatively short-term benign. And treating it with highly dangerous drugs would probably not be a good idea if this is substantiated as we've got longer and longer follow-up. DSA positivity is associated with mild ABMR-like changes of unknown significance in some hearts currently considered to have no rejection. So if we take all the hearts and we distribute them in UMAP, we don't get a bunny. We get whatever this is, and there's rejection, no rejection. And some biopsies that are no rejection, but the distribution says these biopsies have variants that we're not accounting for. So then when we apply the classifiers, we find that these biopsies are actually minor. These are the minor changes biopsies. So needless to say, when we color them by an ABMR classifier, yes, ABMR is red. Some TCMRs have some ABMR as well. So we get these changes, but the biopsies in the minor area have an increased frequency of molecular changes at a very mild level that are typical of ABMR, but they're very mild. And those biopsies, these are the biopsies above the median classifier score. Those biopsies are more likely to be DSA positive. When we look at the lungs, I've had a long history associated with lungs, and of course, one of my sons is a lung transplant physician, so we're deeply involved in lungs. Transbronchial biopsy is a difficult biopsy. It can't be used in sick people, and the lung outcomes are tragically short. So we've been trying to get more information from the transbronchial biopsy, and so now we can read T-cell mediated rejection quite well, but we're not getting a distinct ABMR phenotype in lungs. The transbronchial biopsies we get are dictated by institutional review boards, so we only get one and possibly two, and there is variation in the biopsies. There's structural variation, which interferes with our ability to get clear signals some of the time. We can see TCMR, but the structural variation in endothelial content makes it difficult to see ABMR. We can see clad-like changes. This is weaker than in the airway biopsies, I'll show you. And now we're seeing mild DSA-related changes. Patients who are DSA positive have a very mild gamma interferon release compared to those that are DSA negative. So we are hopeful that we're going to be able to read and interpret ABMR-like stresses in the lungs, which have been very elusive by conventional systems. We're very excited, though, we can read mucosal biopsies because mucosal biopsies are much safer and they're also more reproducible, less piece-to-piece variance than the transbronchial biopsies. So Kieran Halloran and Shafka Shavji in Toronto led us to get biopsies from the third bronchial bifurcation, which is donor tissue remote from the anastomosis, and that's turned out to be a big success. So we can read rejection quite well. Again, we're not getting a distinct antibody-mediated rejection phenotype, and we're getting a better signal for chronic lung allograft dysfunction. We've developed a chronic lung allograft dysfunction classifier for airway biopsies and for transbronchial biopsies, and each of them predicts outcome, predicts failure. We're able then to see the molecular changes associated with CLAD, which is the killer condition which leads to the death of these people. And we are also seeing very mild DSA-related ABMR-like changes, a little bit of gamma interferon release in the airways of patients who are DSA positive. This is our current transbronchial biopsy report from a patient. This patient had some minor inflammatory changes, probably related to injury in the alveoli, but the airways were pristine. So at any rate, we're reading the airways of many of these patients. And it's very encouraging so far that the airway and the transbronchial biopsy for T-cell mediated rejection agree very well. Now for CLAD, we developed classifiers. And the classifiers are predicting a clinical phenotype, a clinical class that is being assigned by the clinician. Histology cannot do this, reading transbronchial biopsies, and histology can't read mucosal biopsies at all. So we've got a classifier for the clinical CLAD diagnosis based on the molecular changes in transbronchial biopsies, and a classifier that is even better in the mucosal biopsies. And each of them predicts future death. Now, the DSA associations are stronger in the TBBs because the TBBs have far more capillaries and microcirculation than the 3BMBs. So we're getting an AUC of about 0.64 for predicting whether a person is DSA positive on the basis of their TBB findings. And that compares to kidney, where the best we can get is about 0.75. And the difference may be not so much that there's less antibody-mediated rejection change, but there's more structural variation in the pieces that we get in the lung. We're excited to work in liver. We think that liver is an unmet need because there are lots of problems that we can have, and because we can take findings in liver transplants and possibly move it into primary liver disease. So we've published the first T-cell mediated rejection paper on livers this summer. And as you can see, we have the president of the ASTS and a lot of other outstanding people associated with us who've contributed these biopsies. And again, this is a worldwide organization, and Sandy Feng has been working with us to help us guide this project. When we look at rejection, we see T-cell mediated rejection in some of the biopsies. T-cell mediated rejection is very early in livers compared to other organs, and then seems to sort of disappear as if the clones are being exhausted. I know this is the liver really behaves differently, and we can see that in the molecular phenotypes. We have an early injury phenotype. But the best thing is that the no rejection phenotype becomes dominant as we go out over time. This is time post-transplant on a log scale, and this is the intensity of the scores we're getting in our archetype models. So T-cell mediated rejection, early injury, and no rejection are the dominant scores. But we are going deeper than that. We know that steatohepatitis is a big problem in populations now, and we've got a classifier for steatohepatitis that is an excellent predictor of whether or not the pathologist will see steatohepatitis in the biopsy. We see the time course of steatohepatitis coming on in this period and then becoming uncommon late. Now, we know steatohepatitis is associated with fibrosis, but there are many other sources of fibrosis. So we have a fibrosis classifier that can give us independently the degree of steatohepatitis and the degree of fibrosis in the biopsy. And we can now start to examine the molecular basis of steatohepatitis, and without going into this too far, it's metabolism. It's not inflammation. And then this is the molecular basis of fibrosis. The beautiful thing here is that many of the top molecules we're seeing in the liver transplants have already been described in primary liver disease as being associated with fibrosis: stathmin, papillin, and the sodium leak channel non-selective protein. So again, I know we get excited about this. Just want to introduce you to one more thing, and this is ongoing, and many of you are involved. This is the trifecta study in which we're trying to take these phenotypes. There's the biopsy phenotype, the donor-specific antibody phenotype, and the cell-free DNA phenotype. We're trying to relate these phenotypes to one another, and this is incomplete. We'll be submitting the work shortly from the analyses. Our aim was to get 300 biopsies. COVID has held us back. Biopsies haven't been done in many centers because of the extent of COVID, but we've already collected 254, and so our new analysis is based on 254. What we're seeing in the relationship between cell-free DNA and the molecular phenotype, and this is basically the same principle in the histology phenotype, ABMR is associated, when it's active, mixed, or early stage or fully developed ABMR, usually gives high cell-free DNA signals. As ABMR burns out and becomes inactive, some of them actually don't give cell-free DNA signals anymore. No rejection usually has low cell-free DNA release, but some of them have high cell-free DNA release. We're trying to figure out why. So far, we can't find anything in the biopsy that actually explains these cases. T-cell mediated rejection was the real finding. Yes, some release cell-free DNA, but some of them don't. These changes are quite compatible with what's recently been reported in the Heart Transplants in Circulation paper 2 weeks ago using shotgun sequencing of cell-free DNA too. So we're excited about these findings. So we got 10 new discoveries I've mentioned: DSA negative ABMR, heterogeneity in TCMR episodes, mild antibody-mediated rejection-like changes of unknown significance in kidneys. We've shown that injury is the predictor of outcomes, not rejection activity. We've shown there's relatively little graft loss in heart ABMR. We've shown that there is Malchus in hearts that we didn't suspect before. I haven't shown you the data because of time, but there's emergence of a late atrophy fibrosis phenotype in hearts. About 20% of the hearts that we get samples from have a phenotype which means they probably have stiff hearts, probably diastolic dysfunction, certainly a little bit of systolic dysfunction, and they have poor outcomes. So this is not rejection. This is probably the consequence of rejection, but it's the atrophy fibrosis phenotype. It may have a relationship to what they're calling CAV. In lungs, we're excited about our findings in TBBs, but even more excited about the potential that 3BMBs could replace TBBs in many applications. And of course, we're very excited about our findings in liver, including our ability to see steatohepatitis and fibrosis. In liver, the low-hanging fruit is really to find out what DSA is doing. In order to do that, we've got to get DSA measurements, and we're working on it. So thanks very much. I'd just like to thank all the people who contributed to this. Louis Hidalgo in Wisconsin has been helping us a lot with the DSA issues. And all of this team that I'm trying. My job is to try to keep this team together and keep the money rolling in. And in that respect, these people have been outstanding, the people that have given us money in the Mendez Foundation. Thank you.
Thank you, Dr. Halloran. I'd like to thank the organizers for the opportunity to share this talk today that I've prepared on post-transplant immunosurveillance for donor-specific antibody. And I like to start this talk with this picture here, which I just think is it's so beautiful, it's happy, it's joyful, it's shiny. These are 30 kidney transplant patients with their living donors. These transplants were performed by the National Kidney Registry. And this picture ran in the New York Times about 4 or 5 years ago. And what I love about it is that it just shows the happiness and hope that is associated with the life and health changing effects of transplantation. And the reason I also really like to show it is because when we look at other excellent, high level, really great quality data like this here from the SRTR, we just don't see those shining faces, even though we're seeing exceptional data. And this data here, the one on top, is showing that deceased donor and living donor transplants are increasing, which is a great thing. At the bottom, you see that there has been a significant shift in transplant of very highly sensitized patients with a CPRA of 98 to 100% since there was a change made in 2014 to allocate more points to these patients in the US and to give them more offers. And what does it look like when we receive a donor offer for a very highly sensitized patient? I have a example of a virtual cross-match that I did right here about a month ago. This virtual cross-match was performed after a donor offer for a very highly sensitized patient being evaluated for their second transplant. The patient had 7 years of UNOS wait time and a CPRA of 99.6%. And this was an 8 out of 12 mismatched donor with 2 DSA. So at the time of the virtual cross-match, this was done sometime in January, and the most recent serum that we had in lab that we had tested for that patient was December 2nd, noted there at the bottom. And in that serum, there were no DSA to the donor, but the patient did display donor-specific antibodies that prior serum that was from September. So these antibodies were not so historic, not so old. They just were not above the positive threshold in the current serum. So I spoke with the physician, the nephrologist, about this case, and I said that I predict a negative flow cross-match. I supported proceeding to transplant with this donor. I said that there would be a risk of antibody-mediated rejection, but that given the patient's broad sensitization and the fact that this was a pretty good donor quality, and I thought that the patient was unlikely to get a better offer given their broad sensitization, I suggested that we should consider proceeding and recommended close post-transplant immune monitoring, which would include a test on day 4 to 5 to evaluate for immune activation and a recurrence of these 2 donor-specific antibodies. as well as longitudinal testing there forward to continue monitoring these donor-specific antibodies and to also assay for the presence of de novo donor-specific antibody as well. And I do this because we all know that allograft survival is significantly reduced in the context of donor-specific antibody. And this is example of data from two studies, separate studies, that show that graft survival is reduced with preformed antibody, as shown on the left in red, or further reduced with de novo donor-specific antibody, shown in black. And in the right, again, de novo donor-specific antibody is associated with reduced graft survival on the right. So what does it look like in the laboratory when we are looking for donor-specific antibody in serum samples? We receive a serum. We use a Luminex-based bead assay called the single antigen bead test to assay for donor-specific antibody. Each one of the beads, it carries one single antigen. And so the raw data, as you see on the left, shows us the strength of the antibodies. And it also shows the specificities. And we report those out to the electronic medical record in a report. And this report for this patient has a comment. The patient displays donor-specific antibodies against B7 of this particular donor in their transplant date. So when I'm evaluating single antigen bead data and evaluating for, turns out that it is a new antibody, or if it is an antibody, a donor-specific antibody that has increased significantly in strength, I'll report it out to the EMR, but I also send a special email to alert the physician or the care team that this patient has a new antibody or one that is significantly increased. And I think this is important to help raise the ability, or raise the communication, and help the clinicians to manage their patients. So there is no one protocol that is globally accepted for post-transplant antibody testing in transplant patients. The testing is done according to center practice, and generally speaking is risk-based, such that patients who are non-sensitized are tested less with preformed donor-specific antibody, or those developing de novo DSA or rejection. These various protocols are substantiated by multiple studies that have been performed, evaluated, and then filtered and condensed here by the STAR working group in 2017, where they showed that there was a high quality of evidence to recommend testing of patients for donor-specific antibody if they are likely to have active memory or be at risk of memory post-transplant. And that's shown here with the 1As under the kidney. And in addition, the frequency depends on the number and the strength of donor-specific antibodies. They also show that for patients who are not at risk of memory, that it would be a good idea to monitor for donor-specific antibody after changes in immunosuppression or at the time of suspected or documented non-adherence. And there at least was a moderate quality of evidence to suggest that testing for donor-specific antibody should be performed at the time of investigation for acute and chronic graft dysfunction, or if there are histologic features of graft injury. So what's going on in the graft at the time when donor-specific antibodies are present? This is a schematic that shows a vessel, and it is surrounded by an endothelium, shown here by these pink cells. And class 1 shown in green, class 2 shown in yellow is expressed on the endothelium, that antibodies bind that and then can upregulate effector molecules such as P-selectin. P-selectin, shown here in blue, is capable of binding monocytes through PSGL1, causing them to tether and differentiate into CD68 positive macrophages and then extravasate into the tissue. Further, CD4 T cells that bind HLA class 2 on activated endothelium can be activated to proliferate, differentiate, and extravasate into the tissue. Antibodies that bind to class 1 can also bind complement, activating the complement cascade and producing anaphylotoxins such as C3 and C5a that serve to further activate immune cell subsets. And NK cells can bind to, via their Fc receptors, to the constant region of antibodies and themselves become more activated and recruit. So what does this look like in the tissue? These are some histologic features of active and chronic antibody-mediated rejection, showing glomerulitis and peritubular capillaritis, C4D staining, and chronic transplant glomerulopathy and peritubular capillaritis. And so when a pathologist, an anatomic pathologist, releases their that they've received, when it comes to a case that has C4D, they may release a report that says something like moderate glomerulitis, G2, and moderate peritubular capillaritis, PTC, 2, and C4D staining of peritubular capillaries consistent with active antibody-mediated rejection. Correlation with donor-specific antibodies is recommended. And in the case where it is a C4D negative with the same G2 and the same PTC2, but without C4D deposition, there is a different disclaimer in this case. And these are, I got these from a colleague of mine here in pathology at UCLA. And the disclaimer here is that correlation with donor-specific antibodies is required for definitive diagnosis of antibody-mediated rejection. And so in preparation for this talk, I was asked to comment on some recent data and pathologists by the 2020 Banff Working Group. And what they found in this survey is that pathologists only around 20% of the time always have the donor-specific antibody data at the time that they're reviewing the biopsy. And for nephrologists and surgeons, it's a little bit better. I propose it could be maybe a day data until they can start to make more clinical decisions and treatment plans, but it's more about 45% of nephrologists and surgeons always have donor-specific antibody data. And the authors of the paper wrote in the abstract that efforts to improve the accessibility of DSA information for the multidisciplinary care team are needed. Some of the reasons why the nephrologists and surgeons, pathologists commented in the survey that they did not have the data was because DSA testing was only performed on certain days of the week, or there was a delay in getting test results from days to weeks, or that DSA testing was not always ordered with the biopsy, and that they had limited communication with HLA laboratories. And so since I direct the quality improvement efforts of the Immunogenetics Center and report to our hospital for our Department of Pathology, I put on my quality improvement hat and I started asking myself, how well do we align reporting of single antigen 1-2 with the reporting of the biopsy results by my colleagues over in pathology? And just a few specs about our single antigen 1-2 test. We have a 5-day turnaround time for stat. We have a volume of about 1,500 single antigens per month for pre and post-transplant antibody assessment. And our monthly QA statistics show that our single antigen 1-2 test is meeting turnaround time at about 98%. In addition, Immunogenetics 24/7 for interpretation of data. And so I wanted to align our single antigen report data. And I reached out to a pathology colleague for a report of all the renal biopsies in the last year. And I realized when I received the report, which by the way is something that he himself has been working on for some time now with a bioinformatics fellow, it turned out that it was going to be hours of manual data acquisition and data entry to get really good baseline data. But I could see by surveying just the last most recent patients that were biopsied that rarely was our laboratory notified that a patient is having a biopsy. And in some cases, matched serum samples weren't sent, and the tests that were sent were not always ordered stat. So it would be difficult to improve and aid the the clinical team without better communication. And I propose that in order to really improve, we need utilities in the EMR that integrate patient data ordered as part of a patient care bundle and to track samples, results, and quality metrics in order to better serve the multidisciplinary care team. So along with these findings, the use of single antigen 1-2, the fact that I think that there is room for improvement. I also wanted to share that there are some emerging themes that have been coming out in the past couple of years that I think could also improve our post-transplant immunosurveillance. This is data from Wiebe and Nickerson's group showing that DR-DQ eplet or epitope mismatch is an independent predictor of de novo DSA development. And in addition, in this paper, they also showed that TAC levels were also independent predictors of de novo DSA development. So in the top figures, what they're showing is that if there were epitope mismatches, and if the number of epitope mismatches between the patient and donor was greater than 12, then there was a much higher risk of de novo DSA for those patients. And that this same risk was not identified when you looked only at antigen mismatches in DR and DQ, and that's shown in the bottom on the left. On the right, those a fairly similar algorithm was used to separate patients into high, intermediate, and low risk categories based on the number of epitope mismatches, and the same was shown in a separate cohort. And so taken together, these studies show that post-transplant immunosuppression, but also immunosurveillance for donor-specific antibody can be personalized to the patient's level of immunologic risk. So returning to the BAMF Working Group 2020, for the respondents who answered, still evidence of changes in the biopsy, and the serum is negative for HLA donor-specific antibody, a large proportion of them noted that they would not order additional testing because it would not change the management on the case. 80% of respondents said that. And 50% of respondents said that testing for molecular transcripts was not available to them, and neither was testing for non-HLA antibodies. So I just wanted to review briefly the tests that are available for non-HLA antibodies and molecular transcripts. In the clinical laboratory, we can test for MICA antibody, antibody to the angiotensin receptor AT1R, and we can also perform an endothelial cell crossmatch on surrogate endothelial cells to identify the ability of antibodies in the serum to target those cells. Molecular transcripts, as you just heard, can be sent out from biopsy samples from my colleague, Dr. Halloran. And in addition, I wanted to add that Luminex bead-based non-HLA antibodies panels are really the future of where we are headed when it comes to testing for non-HLA antibodies. And there in the bottom right is an example of data that we have gathered on a cardiac cohort showing that certain non-HLA antibodies were associated with rejection in those patients. And understanding how the milieu of non-HLA antibodies is contributing to graft damage and loss is an area of intense and much needed research. And since we are also in the age of COVID, I wanted to share with you a very recent study that I have been hearing about, that I've just read about. And this is in patients, actually in children, who after COVID developed multi-symptom inflammatory syndrome. And the paper assesses that all of the patients had evidence of SARS-CoV neutralizing antibody. They all raised an immune response to the SARS-CoV-2 virus. They performed cytokine profiling, immunophenotyping of the peripheral blood, but importantly, in following from my last slide, they also identified autoantibodies, which we usually are referring to in transplant as non-HLA antibodies, including novel candidates that recognize the endothelial cells. And I have some of them listed there, the anti-LA and the anti-Jo1, which have been found to be associated with other known autoimmune diseases, but others that are new. And I think it's important that as we proceed through this pandemic and we see how COVID-19 affects our transplant patients, that we consider that evidence of autoantibodies that target the endothelium, even new antibodies that we've never known of before, could potentially affect the graft, causing rejection, dysfunction, and potentially graft loss. So in summary, I will just say that testing for donor-specific antibodies is important to assess for immune memory and de novo DSA and risk of rejection and graft loss. And that timely and accurate communication of the results to the EMR is very important. I generally tell the fellows that we're training here, don't throw the results over the wall. Don't assume that when you report it, it will result. You should make a critical attempt to communicate that, specially by phone or by email, to the care team. Multidisciplinary care is required for post-transplant patient management. We are also in need of better applications to track diagnosis and metrics on serum and biopsy samples for our patients. And testing for non-HLA antibodies and molecular transcripts in the absence of HLA donor-specific antibody can be beneficial in post-transplant management. And the relevance of this testing may even be increased in the era of COVID-19. I just want to thank you for your attention and your time. And also, I hope everybody is well, and I hope to see you in person, hopefully at the next meeting as soon as possible. Have a wonderful day.
So SARS-CoV-2 and its associated disease, COVID-19, has had a significant impact on transplant patients. Mortality rates as high as 32% have been reported. The presence of COVID-19 antibodies and their levels in transplant patients is critical in assessing risk for transplant procedures. High-risk patients may need higher levels of immunosuppression and would be at greater risk to COVID-19 and false negative tests. Our initiative has been to test for multiple COVID-19 targets that will help increase the accuracy of antibody testing and improve the ability to interpret outcomes from this testing. And it also utilizes a common platform for testing in transplant labs, namely the solid phase single antigen bead testing for HLA antibodies. The lab screen COVID plus antibody assay addresses an unmet need. Most antibody assays for COVID identify a single target, maybe two targets at the most. And because of this, they can deliver false negatives by not targeting the correct antibody, or false positives due to cross-reactivity to common cold coronaviruses. The lab screen COVID plus assay applies a multiplexing approach to deliver a more comprehensive picture of the patient's antibody profile. This more comprehensive picture is provided by targeting 5 unique anti-SARS-CoV-2 antibodies. In addition, 4 common cold antibodies, the MERS, Anagen, and SARS antibodies. The test is provided 100% sensitivity and specificity to reduce false negatives and false positives. It utilizes the XMAP technology, which is the gold standard for multiplexing. Requires only 2 to 3 hours of turnaround time on either the LabScan 200 or LabScan 3D systems. Therefore, it is more accurate, efficient, and cost-effective than testing for these targets individually. Potential examples of situations in which antibody detection with a lab screen COVID plus assay may be utilized to detect whether patients have antibodies following a COVID infection. It's known that not all patients develop antibodies post-infection, and particularly those that have minimal symptoms or an asymptomatic infection. It can also be utilized to determine whether or not vaccines have resulted in the generation of anti-COVID antibodies. This is particularly important in transplant patients as they are immunosuppressed and therefore are known to have reduced vaccine responses. It can be used to quantitate antibodies in patients that receive passive prophylaxis, for example, with convalescent sera, or with one of the new anti-COVID antibodies that can be given for passive prophylaxis, including bamlanivimab, the Lilly monoclonal antibody, and also the Regeneron cocktail. And it can also be used to define the nature of the antibody response, whether there's neutralizing or non-neutralizing antibodies. The detection of antibodies against RBD would give a higher likelihood of developing a neutralizing antibody response. So when this came about, investigators who are listed to the right here from Emory, University of Cincinnati, Stanford, and University Health Network worked together collaboratively with Thermo Fisher to develop this multiplexed assay. This was recently reported and published. The generation of this assay and the validation of it were published in Transplantation. Features of this assay, as we've mentioned, it's a multiplexed panel. It provides antibody response against the following 5 SARS-CoV-2 antigens, the whole spike protein in a trimer fashion, S1, S2, RBD, and nucleocapsid antigens. It also, as we've mentioned, the common cold, MERS, and the original SARS-CoV-1 antibody can be detected. And it's available on both platforms, 200 and 3D platforms. It can eliminate false negatives, provide deeper antigen coverage as compared to a single or duplex detection method. It can detect and benchmark against a prior coronavirus exposure with a common cold coronavirus. Importantly, it can differentiate antigenicity along the spike protein or the nucleocapsid protein, which can help determine whether or not patients have developed antibody responses which are therapeutic or can be deleterious to patient outcomes. And it can also help distinguish the immunity efficacy of the vaccine and also its durability. One of the issues about immune responses, particularly humoral responses to SARS-CoV-2, is that they're known to not necessarily have substantial durability, certainly not along the lengths of durability that are known for measles and mumps vaccines. And so this is a cartoon demonstrating the presence of the virus here. As you can see, the structural spike protein is the major structural protein. It's the major antigenic protein. It's located on the outside of the viral envelope. And the nucleocapsid protein is actually an internal protein, and its its function is actually to encapsulate the messenger RNA nucleic acid material of the virus. Cartoon pictorial version of the spike protein, the S1 portion of the protein, S2, and the RBD are shown here. The RBD is the receptor binding domain. It's important because it's the portion of the antibody that recognizes the human ACE2 receptor. It has also more recently become important because of the detection of mutations that tend to occur in the SARS-CoV-2 genome are concentrated in the RBD region. And therefore, the ability of a neutralizing antibody to retain its neutralizing capacity depends on these types of mutations, and they can affect that. And this is something that the antibody, that this antibody detection platform will have the ability to rapidly adopt new mutant versions of the RBD protein, something that's currently under development with substantial progress already having been made. So here are the beads, negative controls, positive controls, spike protein, whole spike protein, spike S1, spike RBD, spike S2 nucleocapsid, 4 common cold coronaviruses, the MERS spike protein, and the original SARS spike protein. Now I'd like to show you a few results that have been obtained with actual patient samples. This is a patient that has demonstrated positivity across the spectrum of SARS-CoV-2 proteins. Here's your this particular bead and histogram, bar histogram is the whole spike protein. This is spike S1, this is RBD, spike S2, and this is nucleocapsid. As you can see, this patient developed detectable antibodies exceeding 12,000 MFI for all of these proteins. The whole spike protein was actually positive at 62,000 MFI. These are the 4 common cold coronaviruses, indicating that this patient is like most people in the human population, that they have had previous infections with 1 or more of the common cold coronavirus proteins. And this is the original spike S1 from coronavirus. And this is a patient who turned out to be positive to SARS-CoV-2 spike S1 and RBD, what was negative to spike S2 and nucleocapsid. Some patients don't respond to nucleocapsid. These patients tend to have, this is a good profile for protection, having a lower nucleocapsid. Nucleocapsid, as you know, is an internal protein and therefore is unlikely to be blocked from binding by this protein. And then here's your common cold coronaviruses. Patients who do not do well, who tend to get more ill, actually tend to develop greater responses to nucleocapsid than they do to the spike protein. And this is one of the characteristics of human responses that's been published and reported for patients who have more severe COVID disease. And this is a patient that has no SARS-CoV-2 antibodies, has had prior exposure to the common cold coronaviruses, but not to the original SARS-CoV-1 or to the MERS virus. So this was a patient that was actually received a vaccine through the Oxford vaccine. You can see this generated a response to spike S1 and RBD, with S2 and nucleocapsid being negative. Nucleocapsid would be predicted to be negative because that protein is not encoded by this vaccine. This is a whole spike protein vaccine. And again, this patient most likely had pre-existing immunity to common cold coronaviruses. So this is an example of how the multiplexed assay can give you an idea of the response to the vaccine in terms of the nature of the antibodies that are produced. Well, what can we do with this assay in the future? Is there other additional types of information that can be gained through future iterations, or also potentially via people who are using the assay for research purposes? One of the things that may be of interest to people who like to understand the nature of the antibody response, what are the characteristics of an antibody that's protective? What are the characteristics of an antibody that may be injurious? And there's physical characteristics where you can look at the antigen, the epitope specificity, immunodominance, affinity, and avidity, isotype and isotype subclass. People can also look at hinge region glycosylation. Or has been done for HLA antibodies on the similar platform. People can look at complement binding, Fc receptor binding, receptor signaling, and antibody antigen complex mediated immune regulation. So in addition to future iterations of the assay, additional antigenic targets can be evaluated. There are additional structural proteins, envelope and membrane proteins that can be added. There's actual non-structural proteins, including ORF3b and ORF8, which appear to be potentially promising. And then there's also the possibility that when mutants emerge, as I mentioned before, these mutants often have mutations in the RBD domain. So one can actually take a mutated RBD protein and add that on a bead so that one could look at whether or not that patient's antibody profile actually, and its binding to RBD, is affected by these mutations. We can also look, as we mentioned, antibody isotype, antibody subclass, like IgG1, 2, 3, and 4. One can look at IgG or IgM. And then one can also look at the ability of the antibodies against a specific SARS-CoV-2 protein, look at the ability of those antibodies to bind Fc receptors, which would be important for opsonization, and also other mechanisms of viral clearance, and then one can also look at the complement binding capacity. So this is the SARS-CoV-2 proteins. There are functional proteins and structural proteins. The 4 structural proteins are shown here: spike, nucleocapsid, which are both tested in the assay, and then envelope and membrane proteins. These were not included in the assay. They'd appear to be of lesser importance, but it's certainly something that could be included in the assay in future versions. Then there are a number of structural proteins here. And of these structural proteins, some of them appear to be more useful and diagnostically than others. This is a paper from Nature Medicine, which used IgG and IgM levels of SARS-CoV-2 antibodies. As you can see here, some patients have IgM seroconversion earlier than IgG, and some have IgG seroconverting earlier than IgM. As you can see, the IgG went up to higher levels earlier, okay? And some patients actually have IgG and IgM appearing simultaneously. What this indicates is that the usual rules for an early IgM spike followed later by an IgG spike do not necessarily occur in patients that have SARS-CoV-2, indicating that the normal rules, the virus doesn't follow the usual rules that we have for many other infectious agents. This is actually a study that was published in Nature Communications, where the investigators looked at IgG and IgM responses. IgM is over here, and this is IgG. And these heat maps show the level of antibodies produced against these various proteins. And these are each column is an individual patient. So as you can see, there's a fairly substantial response against RBD and the structural proteins here with the IgG, and IgM is shifted away from some of those proteins to where it occurs for different ones. These are patients that have not had SARS. These are actually controls. And so as we mentioned, there are a number of non-structural proteins. Each one of these graphs represents a non-structural protein in patients that had COVID-19 on the left and patients that haven't had COVID-19. And what this analysis demonstrated is that 2 structural proteins, ORF8 and ORF3b, are actually accurate serological markers of early and late SARS-CoV-2 infection. These are actually assays that have already been developed and could be included in future versions and future iterations of the COVID antibody assay. So complement binding is something that's been used. C1q binding has been used to analyze HLA antibodies and their functional properties. And in an identical way, C1q binding can be developed to determine whether or not antibodies detected in this multiplexed assay against COVID have the ability to bind complement. We've also developed in our laboratory an Fcr panel where the ability of a SARS-CoV-2 antibody or an HLA antibody can be tested for its abilities to bind specific Fc receptors, like important Fc receptors, like the high affinity Fc receptor expressed on macrophages, or maybe the FcR3, a CD16 antibody, which is known to bind to Fc receptors located on NK cells. And finally, this is some work that has come out of Galit Alter's lab, where she looked at a more comprehensive way at not only antibody isotype, antibody ability to bind complement or Fc receptors, or neutralizing capacities. As you can see, these are all violin plots showing activities against spike, RBD, and nucleocapsid antigen for IgA antibodies, IgM antibodies, and also IgG. And then these are actually functional assays that they looked at. This is antibody dependent cytotoxicity. This is an NK mediated assay. This is antibody dependent cellular phagocytosis. And so this illustrates how these types of multiplex assays can actually give you information in a global fashion regarding the functional capacity of an antibody. And these are from the same paper with data presented via a Nightingale plot. And what they did is they looked at convalescent patients and compared them to patients that did not survive COVID infection. And they looked at their global antibody responses to spike protein, RBD protein, and nucleocapsid. And what they found, as you can see here, that deceased patients tended to have bigger antibody responses to nucleocapsid, that they had a very wider variety and higher levels of isotypes, that the cellular function was also more important. But if you look into convalescent patients, these activities were largely directed to spike, indicating that the neutralizing activity of an antibody profile in a patient tends to correlate with whether they survive or expire from SARS-CoV-2 infection. So in summary, antibody responses to SARS-CoV-2 in humans demonstrate considerable heterogeneity with the type of antibody, its functional capacity, and its levels. The antibodies responses also differ between people who are asymptomatic and people who are symptomatic. And antibody responses also differ between survivors and not.
Well done, guys. So welcome to the panel discussion portion of this meeting. So maybe I'll start out by asking a question of Steve. So, you know, we know that immunosuppressed patients were not included in the original vaccine trials, and there's, emerging data from the frontline workers who also have solid organ transplants or bone marrow transplants or immunosuppressed for autoimmune diseases or cancer, that there may be either absent or reduced immune response in these patients to the vaccine. I myself, after my second dose of vaccine, 2 weeks after the second dose, had not developed any detectable antibody, although I'm happy to say that I just got a text actually from the folks using your platform that it does appear that I do have some antibody now, but it's quite low level. So, there's going to be a lot of interest in what's going on with the transplant patients and whether they're getting protection from the vaccine, at least the 2 vaccines that are currently available, now 3. So, the types of testing that you're doing, I think that, really reflect multiple different targets for these vaccines are going to be extremely important, because there's a lot of confusion about which commercially available platforms can actually be relevant to the vaccine. So I think this is a really great innovation. But I just wanted to ask you specifically, your platform, is it only measuring IgG? And what are your thoughts about IgA and the importance of IgA in terms of preventing infection? So I'll just leave it at that, Steve.
Yeah, Bob, you really, even with your personal example, you've hit on a major issue that we think is a big concern in transplantation, is that you cannot just assume, as you do in the general population, that transplant patients are going to have a 94% protection from these vaccines. And it could be substantially less. I didn't share this with you before, but I actually have very high titers after the Moderna antibody. But I am a 17-year-old liver transplant recipient on minimal immunosuppression. So I had a very vigorous response to the vaccine. And I think our 2 examples highlight that there's a diversity of patients in the transplant population, and you just cannot assume to what the response is going to be. I think it's going to be absolutely critical to incorporate standard antibody testing in COVID vaccinated transplant patients so that you can develop a treatment plan. For me, I really don't, I shouldn't have a problem with most COVID infections. The chances of me having a severe infection are low. For you, Bob, if you have a very low level and you were to develop a symptomatic COVID infection, you need to be treated with Bamlan or Regeneron. And so just using this test can tell doctors exactly how their patients need to be managed. So the doctor, for example, if I was your doctor and you were in my clinic, I would say, look, if you get symptomatic with COVID, go get tested. If you test positive, call me right away, because you can't give Bamlan if you're more than 10 days out from the onset of symptoms. And so these are the types of treatment algorithms that this type of testing can help us develop. And so one of the other questions is going to be, what about should patients who have already been exposed to COVID receive the vaccine. We don't know what the response is going to be. And so with this assay, we can tell which antibodies are from prior infection. That is, if you have a nucleocapsid antibody, you've been infected. And they can tell whether or not the infections are, whether the antibodies are from a vaccine. For example, if you get Moderna, you're going to generate RBD and spike. So that's why I think part of the reason why we wanted to develop it. And the other thing, I think that our other speaker mentioned the issue of the multi-systemic inflammatory syndrome in children. Galit Alter has now shown that the kids who develop that are the kids who develop high-level antibodies, and the antibodies have a big functional capacity. So the ability to take this assay and look at its Fc receptor binding capacities of specific antibodies is important. The assay is it's set up now as an IgG, and that's most important. But by changing the secondary antibody, you can look at IgM or IgA. The importance of IgA antibodies has not yet been reported, but there's a lot of interest in them because, the vaccine starts in the upper respiratory tract epithelium. So.
Great, thanks, Steve, for that. So that I just got a question in that's related to this. Can you speak more about the importance of DSA testing, and this should be for Michelle, with COVID exposure or the COVID vaccination? Is there any evidence of an increase in DSA either from the vaccine or the illness? Michelle, do you know of any data?
Thank you for the question. Yeah, I don't think we have good data yet that the vaccine boosts, say, the presence of current DSA, makes it stronger. I think it still remains to be seen. I've also been wondering about when patients get COVID and, say, transplant patients get COVID and maybe their immunosuppression is reduced or adjusted, they may need closer monitoring after that. So I think that there is a place there where DSA monitoring and transplant patients after COVID is probably very important. Actually, that was in the STAR guidelines as well. If you have to reduce immunosuppression for any reason, it's a good reason. It's a good reason to check for DSA.
Yeah, I think most clinicians managing transplant patients when they've been infected with COVID have either reduced or eliminated the anti-metabolite. And there is some evidence, and I'd be interested, Steve, whether you're on an anti-metabolite, whether you're on CellCept, but there's some evidence that I've seen from our vaccine center in autoimmune patients and also from the Hopkins emerging data that it may be the anti-metabolites that are blocking the antibody response. But of course, what we do see is that in those patients where we stop the CellCept who get the disease, they seem to get very robust antibody responses. But as you say, Michelle, that begs the question and the concern: are they going to be at higher risk for developing de novo DSA or getting a rejection episode?
Yes.
So, Bob, I think one of the things that's come out in the testing is that survival from COVID, when you fail to survive COVID, is most likely due to an early poor gamma interferon response. And so I think the best thing to do in a transplant patient is tailor their immunosuppression so that you maximize their ability to produce gamma interferon. That's just with the virus. I'm not saying that may be a bad thing to induce rejection, but it's very clear that the people who fail to survive COVID have very poor gamma interferon responses. And that's probably the strongest data from an immunologic mechanism that exists to explain why patients don't handle it well. I think reducing MMF may not be the best thing. It may be the best thing may be to reduce tacrolimus. That remains to be shown in a clinical trial with patients. That's what we really need.
So Christopher Lawrence, Dr. Christopher Lawrence has joined us to stand in for Phil, because Phil is getting his COVID vaccine right now and is in line and wasn't able to make it back. So this is the world we live in right now. So I've got a question for Chris. Let me just find it here. And this has to do with the molecular microscope, and so the fact that that we don't have a morphologic correlation with these samples, how can you be sure that the samples that you receive are representative?
Well,
does that make sense?
Yeah, that makes sense, Bob. Thank you for the question. So it's a new side effect of the COVID vaccine. You lose 20 years, gain 40 pounds, and a British accent. So in terms of the representation of the biopsy, the first thing I want to say about that is that the biopsy comes from the same place that the biopsy that goes to the histopathologist comes from. So when I do a kidney transplant biopsy, I take two 18-gauge cores set at a 13mm strike distance, and I take 3mm from the end of one of those cores. When we're sending MMDX heart, we're taking one of the 5 bites from the bioptome. So it's going to be as representative as the sample that's sent for histopathology. I'm going to suggest that actually not having morphological correlation isn't a particular problem. Having morphological correlation doesn't tell you that it doesn't guarantee that the biopsy is representative of the whole organ. If you hit a bit of scarring in the kidney and it's all interstitial fibrosis, tubular atrophy and inflammation, that may well just be a scar, that may well not represent the whole organ. I'd argue that MMDX is possibly more likely to be representative of what's going on in the whole organ than the histopathology under those circumstances, because I think the molecular changes are more likely to be evenly distributed through the organ rather than the histopathological evidence of the damage. And of course, the MMDX takes out the inter and intra variability of interpreting that. One of the interesting things about kidney, of course, is that when you send kidney biopsy, if it's all medulla, the histopathologist can't read it because BAMF rules don't let you. You need to have a certain number of glomeruli in order to report it. MMDX can report medulla. We'd rather it was cortex. We can tell, even though we haven't had a morphological assessment, how much is medulla and how much is cortex from podocin expression, which is only found in cortex. And we know that reading medulla will overestimate antibody-mediated rejection, but we can correct for that, which of course you can't do with histopathology.
I don't know about everybody else, but I kind of like the new improved Phil Halloran. Anyway, so I think we're at the end of our time, and I just want to thank the audience for joining us today, and thank our extremely talented speakers for delivering really clear and succinct talks about some really exciting areas of investigation, moving us towards precision medicine and a more personalized care of our transplant patients. Thank you very much for your attention, and have a good day.
Thank you.